Hello, everyone. This is Bob Sullivan. We're going to cover lifespan development. We're going to brief overview for EMT 101. And part of that, we're going to talk about from developmental stages, both physically, emotionally, developmentally, from infant to geriatrics, and how we're going to adjust some of our treatment based on age and developmental stage. We're going to start with infants. Infants are aged 1 month to 1 year, so the 30th day that they're alive to 1 year, their first birthday, they're considered infants. Before 30 days, they are considered neonates. And initially, immediately after birth, they're considered newborns. So the average weight is 7.5 pounds, and they actually lose weight by week one. That's normal. And then they gain it back during week two. So this is something they'll be following up with their pediatrician about, whether that's normal. So ask when you're doing your assessment, you can ask mom about the weight changes, and then they should have an idea about that based on the pediatrician's visits. So prior to circulation, the blood gets transferred through the placenta, and there's a transition period after they're born where they go to their own vasculature. The ducts in the heart close, normally close during that period, and they go through their own systemic circulation. The first breath is triggered by sensory changes. So the drying of the vernix, the birth fluid, that's going to stimulate them to breathe. Their CO2 level is going to grow up. That's going to increase. That's going to trigger them to breathe. So infants are obligate nose breathers, and they are prone to nasal congestion. So some little nasal congestion can go a long way to cause them to have difficulty breathing. So you'll see signs of retractions. You might see grunting, and sometimes if you just clear out their nose, that'll get better very quickly. So you'll see, and especially at like the children's hospital, they'll have I guess it's lack of a better term, a booger sucker. So bring in children, they'll use that, and they can get better really quickly. So just remember that they're obligate nose breathers. Congestion can cause airway compromises. So the other difference between infants and older patients is that the rib cage is softer. Um, the diaphragm is the muscle. The diaphragm drives um, breathing more than older patients. The intercostal muscles are immature. They're going to have less accessory muscle uses to use in the chest. Most of that's going to come from the diaphragm. Um, they have a larger tongue. They have a shorter, narrow airway. The large tongue can make airway management difficult. So they're at higher risk for an obstruction. They have fewer alveoli. That takes away some of the reserve that they have. And the lungs are fragile. So if we ventilate them too aggressively, we can cause a pneumothorax. We can cause their lung to collapse. We want to be very careful just manipulating their airway and with our positive pressure ventilation. And you'll notice when in this picture here that there's a towel under the shoulders. So when we're ventilating an infant, because of the shape of the head, if we lay the patient supine, their head is going to flex forward. So that is why we want to put a towel under their shoulders, and we want to adjust that so that they're looking straight up. So have the airhead position, put a towel under the shoulders. So keep a towel in your pediatric bag or even in your adult airway bag. And pad enough under the shoulders so that they're looking straight up. And be really gentle. We should be monitoring how much we're ventilating them. We should monitor the pressure with the PEEP and our inspiratory pressure. And there's actually a device called the NEOT, which with infants and neonates can help us guide how much pressure we're delivering to reduce the risk of injury to their lungs. Okay, so children are at risk for dehydration, electrolyte imbalances. So ask about urination or lack of urination if they are dehydrated. For the first year, they have passive immunity from the mother, and they'll gradually develop that as they get older from adaptive immunity. Um, they're born with reflexes, so they'll grasp your palm. If you normally is if you put a finger next to their mouth, they'll look towards it. Um, and then there's also a sucking reflex if something approaches their lips. These will suck. Okay, so one of the signs of a great assessment tool in infants are the fontanelles. So the fontanelles are not molded yet. So one of the things to assess for is if they are sunken. So sunken fontanelles are a sign of dehydration, and bulging fontanelles are a sign of a head injury or increased intracranial pressure or a disease like meningitis or something where there's increased intracranial pressure. You'll actually see bulging fontanelles. So the fontanelles are a great assessment tool to figure out how to treat infants and to identify what might be wrong with them. The musculoskeletal system, there are growth plates because there are growths that are still bones are growing. There's growth charts that track growth of infants and children, and a parent might be able to tell you what those are or where they are at the rate of that. Teething. Teething can happen 4 to 7 months. If you ever had a child teething, you'll know that that's fun and you'll there's some sleepless nights. Um, but along with the teething is you can get fevers from that normally. So that's one of the causes of a fever if mom calls for that or a parent calls for a fever. Um, the baby teeth are in by 3, and the smaller teeth start falling out around 6. So these are ages, and these are just general guidelines for characteristics of various ages. Kids follow their own schedules; they will not adhere to all of these things. But one of the things that we're looking for is the child sick or not sick? And by age 2 months, what they you want to see if they're going to, right? They'll recognize familiar faces, they'll track objects. Um, they'll reach out to people at 4 months and they'll drool. 5 months, my children did not sleep through the night at 5 months, but they'll recognize strangers. And by 7 months, they should have some stranger anxiety. So if the parent calls 911, after like 6 or 7 or 8 months, and the child should be a little worried that a stranger is coming into their house that they've never met you before. So if they're just kind of staring straight ahead and they are not interacting with the environment and they really don't notice you walk in and they don't care that you're assessing them or you're getting in into their space, that is a red flag. That is a sign that the child is sick. So when we're doing our initial pediatric assessment triangle, how does the patient look? If they're not noticing you walking in, if they're not either interested in you or they're not even like a little scared, that is a red flag that the child is sick. It's a abnormal appearance. Um, and around 8 months, they can start saying no. They recognize their name about 10 months, and then 11 months, they start walking with assistance. So, so attachment, there's different types of attachment for children. There's secure attachment styles. There's avoidant attachments if they're afraid of rejection. So most of the time, infants are crying as a method of communicating distress. A crying child is always uh, is less concerning than a sleepy, drowsy kind of child that looks like they're not interacting with the environment. So crying, they're communicating distress. Another red flag is inconsolable crying. So the child can't be consoled by the mother or the caregiver that's holding them. Um, so and when they respond to a crisis, there's 3 phases. They'll protest, they will maybe swing their arms, they'll cry, um, and then they kind of despair. And when they withdraw, that's the red flag when they're just checked out of not interacting with the environment. So they need a predictable environment to be secure. Unfortunately, EMS goes into a lot of environments that are not predictable for children, and their baseline is chaotic. So some of the attachment issues may not be intact for the environments that we're going to go into. when we're assessing children, um, we want to try to let the caregiver hold the child. And we want to try to get down to their level. So that's going to involve usually a lot of times the parent will be sitting down, the child will be on their lap, will be holding the child or cradling the child. And then that's when you want to get down on the child's level and get down on the knees or the floor and assess them while they're holding them. Now you notice the paramedic in the picture is listening to lungs. If the child is not crying, they may start crying as soon as you start assessing them. So the window to get the lung sounds is first thing. They may actually start crying once you pull the stethoscope out. So try to get the lung sounds early. So kind of make some eye contact, gain some trust. Infants, we want to generally we want to assess from the toe up towards the torso. But we want to get the lung sounds early because as soon as they start crying, we're going to lose the window to get those probably. Okay. So toddlers are 1 to 2 years of age. Preschoolers are 3 to 5 years of age. And the vital signs are going to be the infants, their baseline is going to be higher pulse and respiratory rates. They're going to start to come down for toddlers and preschoolers. One of the ways that children, toddlers, and preschoolers compensate is with the heart rate. Whereas adults, we can compensate with some contractility also. So you'll see children with really high heart rates to compensate for things higher than you would see with adults. So we can get into the vital signs of a heart rate of 180 to compensate for, say, dehydration. So we're going to lose some of the musculature of the cardiovascular system. And now we're going to get acquired immunity from the environment. This is when they develop gross fine motor skills, and the brain actually weighs 90% of what their adult weight grows. So this is why the head is disproportionately larger, especially when we're calculating burn surface area. The head is proportionally larger than the rest of the body, and then as adults, the rest of the body catches up to the brain and the head. So as toddlers and preschoolers develop bowel and bladder control, if you've done potty training, that could be an issue while you're transporting someone if they have to go to the bathroom. Um, there'll be teething. The teething may include the fever. Um, they might like to be, I would never tickle a patient, but the children may respond to this if to build a rapport. But this is where the sensory development is where children can be tickled. So this is when they get separation anxiety. This is when, if the child doesn't care that they're being separated from a caregiver, that is a red flag. It may even be some abuse or neglect issues going on, but we should see some separation anxiety. The child should not just go with you to the ambulance without some look of concern at least. And towards the end of preschoolers, this is where they begin interacting with peers. They recognize sexual differences. They start modeling other people's behavior. So with toddlers and preschools, again, we want to position ourselves at eye level. We're going to always explain what we're going to do. If we need to give a shot, so anaphylaxis, we're going to prepare it, but we don't want to tell them that we're going to give it until the last minute. But we're always going to explain everything we're going to do. Should never be a surprise. Uh, we always want to be honest with what we're going to do. If the patient asks, "Are you going to give me a shot?" If they need one, don't say no. They're going to stick me with a needle. If they need an IV, we don't want to say no. We want to try to say things. Yes, you're going to feel a pinch for a second, but then it'll be over. Things like that. So we want to include the caregiver, but we also want to talk to the patient. So when you have a toddler or preschooler, ask them what's wrong. So mom is probably the one who called, or dad is probably the one who called. So get like a little brief overview from them, but then include the caregiver. Don't only talk to the parent. Include the child. Don't only include the parent. They can tell, a lot of times the child can tell you what's wrong with them. So these are some styles of parenting, authoritarian. There's issues with they may have little or no rules. They may have lots of rules. All of this can affect just the scene dynamics, dynamics with siblings, other caregivers on scene. And there may be divorce issues with parents. Sometimes parents may disagree about whether the child needs to go to the hospital or not, and that can be a real challenge that we need to navigate. And so we're going to go to school age children, ages 6 to 12 years. So the vital signs are close to what adults would be, but again, they're going to have some higher heart rates still to compensate for things, more than contractility and vasoconstriction. This is when puberty starts. There are some psychosocial changes where the child will want to avoid punishment to get what they want. They may try to gain approval from they may try to gain approval from their peers. This is when self-concept develops. They develop a consciousness. So um, this is when they develop more of a sense of right and wrong. So gaining and losing trust is a huge issue. So you always want to be honest, direct and assertive. Now, adolescents are ages 13 to 18 years. So this is the vital signs are similar to adults, they're getting the more vasoconstriction. The blood chemistry is the same. Um, Boys experience rapid growth later than girls, and muscle mass and bone density are close to adult level. So then secondary sex characteristics. So American Heart. So the signs of an adult when you start treating a child as an adult, use the adult defibrillation pads is uh, signs of armpit hair in boys and breast development in females. This is when menstruation happens. Um, and this is when we need to start asking questions about last menstrual period or have you had a menstrual period yet? There may be some questions that we want to ask that they may not answer in front of the parents about sexual drug use, sexual activity. These are some things that we might need to know and kind of dance around asking these questions when the parents aren't there. So this is when there could be family conflict. This is when there could be some drug use, rebellious behavior. Unfortunately, that can lead to car crashes, peer pressure, there's poor choices, self-destructive behavior. So I see like cutting, I see self-harm, intentional self-harm, suicide attempts. These are really sensitive questions that we need to ask in a way that's compassionate and a way to gain the child's trust, the parents' trust. We respond to calls at schools. This is the parents will call, and sometimes there are things that we need to learn when the parents aren't within earshot. So this is just one of the things to think about. Utilize your resources and your caregivers, your other responders also. So we want to respect adults and teenagers. We want to separate them from the caregivers to get information if possible, if it's necessary, um, and treat them with adults. Treat them the way that you would an adult. Okay, so early adulthood. This is the body's ultimate optimal level between ages 19 and 25. Everything starts going down after that. Uh, Work, family, and stress shifts the main focus as children go out into the world and start taking jobs. They start having children, finding life partners. So middle-aged adults, this is when the hearing loss starts, the cardiovascular diseases, so ages 40 to 60, metabolism drops, rates of cancer, menopause starts. This is when we start adding medications, and we have like, polypharmacy. Patients start taking, this is the window for the blood pressure medication, the cardiac cholesterol medications. And these are when we're starting to see those changes. So the children may be moving out. This is empty nest syndrome. So financial problems may develop, retirement, um, maybe more adept to handling crises. And so now we're getting to late adulthood. This is when we're going to see the majority of EMS patients, or a large percentage of them are over age 60. Um, and then we're going to deal with medications, body changes. Um, the life expectancy is now expected to be 77 years, but we see patients that are a lot older than that, who still have a high quality of life. Okay, so the cardiovascular system, this is when we get atherosclerosis. So there's blood vessel blockage. And this is going to be from high cholesterol is causing the blockages. Um, the heart's less able to respond to exercise or disease, depending on the physical condition you're in, and the vascular system becomes stiff. So this is important because when we're going to compensate for shock, one of the things that ways that the cardiac responds is the heart responds is to increase the heart rate and to decrease vascular size for vasoconstriction. As you get older, when you get into this age group, your heart and your body is less able to respond to those changes. It is less, it will not adapt to stress as quickly as when younger adults. So structural changes make breathing more difficult, so the ribs become calcified. So remember that we had those really spongy ribs in infants. Well, now they're very rigid, and this can make breathing more difficult. The upper airway and nose are less protected. So the muscles in the lower airways are more prone to collapse. And you cannot take as deep breaths, so your vital capacity is decreased, your residual lung volume decreased. So all of this means that you're going to, if you were to stop breathing, you're not going to be able to compensate for lack of oxygen as quickly as with younger adults. So diabetes is can happen at this stage. And it's related to weight gain, so type 2 diabetes. So it changes the reproductive system, and so as menopause is taking place. Um, both sexes may experience less sexual desire. So the other thing with the renal system is also the heart is going to compensate for shock by increasing the rate and blood vessel contraction, blood vessel constriction. And with the renal system, another thing is adjusting how much fluid is retained or excreted. Sometimes medications, so ACE inhibitors, will interrupt the body's response by retaining or excreting fluids. So as the kidneys get older, this is another way that the body is less able to compensate for stages of shock. In the GI system, there's less taste. There's weak teeth, so dental issues may take place. They may affect nutrition. There's less saliva, gastric motility slows down. There's less acid that gets secreted. Fewer nutrients get extracted in the small intestine, and incontinence can be an issue. And so this is one thing. So the nervous system changes. The brain actually loses weight. You lose neurons and you lose frontal lobe synapses. And one of the things with the nervous system is that the small brain leaves room between the skull and the brain, and there's this room for bleeding. So geriatric patients are at higher risk for some bleeding in the brain, like a subdural hematoma, because there's more room. The brain is actually going to move. There's going to be could be some shearing, a lot more space in the brain between the brain and the dura mater. So nervous system, so decreased sensation, slower reflexes, slower ability to respond. It may have more difficult time answering questions. There may be a delay. You ask a question, you have to wait a second or a few seconds before the patient can process it and respond. There's less sensitivity to cold and heat. So not only are your body going to be less able to compensate for changes in temperature, we see this with extremes in the winter and summer with extremes of heat and cold. How, a lot of older patients can die in their home if it's not air conditioned or heated properly, because they won't realize that they feel cold, and then their body is less able to compensate for them. So vision, this can cause some falls. They're less vision's less acute. They lose visual acuity. The ocular movement may be restricted if you check the H pattern in geriatric patients, and all of that may be delayed. Now they have difficulty with focusing, and they may lose their peripheral vision. So all of this like leaves them at risk of injuries. So there's hearing loss, deafness. So you may need to speak slowly and clearly towards the patient's ear to get them to so that they can understand. This can be a big challenge caring for patients with hearing loss. And so psychosocial changes until 5 years preceding death, most adults retain a high level of brain function. Many still live at home. So isolation is a concern. If you're financially stable, you might be able to go to assisted living. Patients are facing their own mortality. Some are at different levels of um, being okay with that. Many are participating in life actively. So just because the takeaway from this is if a geriatric patient has an altered mental status, do not assume that that is their baseline. We always assume that the patient's alert and oriented with normally, unless a caregiver or a nursing home staff member can tell us something that's different. We always want to assume that the patient has a normal baseline level of mentation that's normal. And that is the overview of lifespan development.